Hey guys, we're going to talk about lymphomas. There's two types of lymphomas, Hodgkin's and non-Hodgkin's. And we're going to start by talking about Hodgkin's lymphoma first. And Hodgkin's lymphoma makes up about 10% of all the lymphomas that we see. And this Reed-Sternberg cell is a very important part of Hodgkin's lymphoma. Basically, as you can see, it's an abnormal, giant, multinucleated, you can see that here, multinucleated cell, and they're called Reed-Sternberg cells, and they're characterized by Hodgkin's lymphoma. So if we look at the next slide, which is the patho, the disease really starts in a single location, such as the cervical nodes. 60 to 70% of Hodgkin's lymphoma will start in the cervical node and then spread along adjacent lymphatics. And eventually it can spread to the lungs, spleen, and liver. And this lymphoma, Hodgkin's lymphoma, has what's called a bimodal age. So the incidence of Hodgkin's lymphoma is between the ages of 15 and 30, and then again above the age of 55. And we have some known risk factors, but really what we know about Hodgkin's lymphoma related to the cause is we really don't know what causes it. The risk factors for Hodgkin's lymphoma is infection, such as the Epstein-Barr virus. We also see this increased in patients with HIV infection. There's a genetic predisposition, and it is higher in men, and we see it with first degree if there's a history of a first degree relative. There are also exposure to occupational toxins as a risk factor. And those are pollution, asbestos, lead, and arsenic. But the good thing with Hodgkin's lymphoma is that there is a long-term survival rate of greater than 85%. We have two categories of clinical manifestations. We have our early, which is those enlarged lymph nodes. We can see weight loss, fatigue, weakness, fever, chills, night sweats. These are called group A clinical manifestations. And then we can also see late clinical manifestations. These are more advanced, where we'll see an enlarged liver, hepatomegaly, and enlarged spleens, splenomegaly. Make sure you know those terms, because we won't say enlarged liver or enlarged spleen on the exam. You'll see the medical term. We also see anemia in these patients, and it results from two things: an increased destruction of red blood cells and a decreased production of red blood cells. The onset is very often insidious and slow. And as I said, there's two groups of clinical manifestations. Group B is thought to have a worsening prognosis. About 10% and see this in 6 months. Then we have the group A, which are your early clinical manifestations. How do we diagnose Hodgkin's lymphoma? We look for an abnormal CBC, first of all. These are variable, so CBCs are really not used to diagnose it. We really look at the anemia. They'll have microcytic hypochromic anemia. They will have hypercalcemia from the bone involvement, or they could also have hypoalbuminemia from the liver involvement, which means their albumin will be low. We also see the PET and CT scans used to assess the response to treatment. These aren't usually used to diagnose. The PET scan is used, and the CT scan are used to stage Hodgkin's lymphoma and assess if it has spread to other areas. We see radiologic studies done. These define the sites and determine the stage. and we look at bone marrow examination. We want to look at the cells for Hodgkin's lymphoma. Treatment options with chemotherapy. Many medications are used by stage, so we see early chemo is done, and the types of meds that are given are adriamycin, bleomycin, vinblistine, and dacarbazine. Late is bleomycin, etoposide, adriamycin, cyclophosphamide, vincristine, and procarbazine and prednisone. So what we found is there's almost a trial and error, but a combination therapy works really well. The other thing we need to know with treatment options is they are at an increased risk for superior vena cava syndrome. And this is where the superior vena cava is partially blocked or compressed, and this carries blood from the head, the neck, and the upper chest and arms to the heart. And so these patients will have difficulty breathing, they'll have shortness of breath, they'll have coughing, swelling of the face, neck, and upper body and arms. And so we need to be cognizant of that and assessing for that as the nurse. Nursing diagnoses, I'm not going to go over those because NCLEX doesn't test you on those anymore. But when we look at nursing care is focused on pain from the tumor. It's focused on assessing for superior vena cava syndrome and pancytopenia. So pancytopenia, you'll see decreased white blood cells, decreased red blood cells, and you'll see decreased platelets. The treatment needed for this is really support during treatments. There's lots of fertility issues, and they're more prominent as the disease presents at a younger age. And then monitoring long-term effects of the therapy due to the delayed consequences. We want to screen for secondary cancers such as lung and breast cancer. And then we have non-Hodgkin's lymphoma, which was our second type. So the most common in the United States is this top star. The B-cell lymphoma originates in the lymph nodes, usually in the neck and the abdomen. This is really a broad group of cancers of primarily B cells and T cells, natural killer cells. They affect people of all ages, and the cause, like Hodgkin's, is unknown. But there are risk factors for this disease. Again, it goes back to infection, which is the Epstein-Barr, hepatitis B and C, and H. pylori. We also have environmental factors as risks for this disease process, and these are chemicals such as pesticides and herbicides, some organic chemicals. And then immunodeficiencies is a risk factor. So meds, for example, if I had a kidney transplant, meds for organ rejection, autoimmune disorders such as lupus and rheumatoid arthritis, chemo and radiation fall under that because they impact the immune system. Clinical manifestations of non-Hodgkin's lymphoma. Most have widespread disease at the time of diagnosis. What we know is that the clinical manifestations is that the lymph node, it's a painless lymph node enlargement. That's the most common symptom, is that it's painless. They have these enlarged nodes, but there is no pain associated with it, which is different from Hodgkin's lymphoma. We also can see hepatomegaly with non-Hodgkin's. We also can see neurological symptoms. Non-Hodgkin's lymphoma can manifest in very non-specific ways, such as we can see an airway obstruction or a mass. We can see renal failure from what's called tumor lysis syndrome, and this is where meds kill the cells and release uric acid, which leads to hyperuricemia. The meds used for this are allopurinol. We can also see pericardial tamponade, and we can also see GI symptoms. So you can see that these clinical manifestations are very nonspecific. There are diagnostic studies that we can do for non-Hodgkin's lymphoma. They are the same as the ones done for Hodgkin's lymphoma. Due to the involvement of the extranodal sites, an MRI may be used to rule out central nervous system or bone marrow infiltration. We can see also an MRI or a lumbar puncture to rule out that central nervous system disease. Bone marrow biopsies are done to determine bone marrow infiltration. We can also see a barium enema or an upper GI to look for GI involvement. Treatment options for non-Hodgkin's lymphoma. We want to observe until the disease progression for asymptomatic patients becomes symptomatic. So it's kind of a wait and see. We want to look for low grade. These patients tend to live longer without treatment, so that's why we kind of want to use a wait and see approach. Some patients with indolent or low-grade lymphoma may live 10 years without having any symptoms or treatment at all. These patients with H. pylori can be treated with an antibiotic or an antiviral. And some with low-grade non-Hodgkin's lymphoma may be treated with rituximab. So there's an alert, and I would look at that drug alert for that medication on page 644 of your Lewis book. We can also see stem cells done and radioimmunotherapy done for treatment options. But typically what I want you to understand is it's truly a wait and see approach. Nursing management for non-Hodgkin's lymphoma. Again, I'm not going to go over nursing diagnoses, but how is this disease process managed? We're going to look at managing pain. We're going to look for spinal cord compression and tumor lysis syndrome. We're also going to be aware of and look for more organ involvement due to the lymph node spread. So we're going to look for GI involvement. We're going to look for hepatomegaly, splenomegaly. We're going to look for bone marrow infiltration. And we really need to make sure that we're providing support for the patient and the family, because this is very hard and a difficult time for them when they're told they have a non-Hodgkin's lymphoma. And that's all I have for the lymphomas. So please know if you have any questions at all, please don't hesitate to reach out to me, and I am happy to answer any of your questions.